Welcome to the lecture on chest trauma and chest surgery. Chest surgery is actually a form of chest trauma, and so you'll be able to see that as we go through the lecture. Just as a warning, there are very graphic pictures in this lecture, so if you have children or anyone with a weak stomach, you don't want them nearby when you are viewing this particular lecture. The normal respiratory function is dependent upon the integrity of the thoracic wall, pleura, and lungs. Thoracic injuries occurred in over 194,000 patients and accounted for almost 23% of the types of trauma recently recorded in a national trauma database. And this is from the American College of Surgeons in 2016, so those numbers are probably much higher today. Chest trauma is classified as either blunt or penetrating. Blunt thoracic injuries account for 20 to 25% of deaths due to trauma and contributed to 25 to 50% of remaining deaths. 4 of the 10 complications or top complications in trauma are pneumonia, DVT, PE, unplanned extubation, acute lung injury, or ARDS. Major chest trauma may occur alone or in combination with multiple other injuries. These are our objectives for this lecture. We're going to talk about the incident causes, prevention, and treatment strategies for problems requiring chest surgery. We're going to develop a nursing care plan. I'm going to explain the principles of chest drainage and nursing responsibilities. We're going to identify signs and symptoms of complications and pharmacological treatment following thoracic surgery. We're going to discuss nutritional components, describe 2 classifications of chest trauma and clinical manifestations, and the complications of chest trauma and their clinical manifestations and nursing management. Chest trauma is divided into 2 types, blunt and penetrating. Blunt trauma can result from sternal and rib fractures, flailed chest, and pulmonary contusion. In penetrating trauma, any organ or structure within the chest is susceptible. Some examples are the chest wall, lung and pleura, the tracheobronchial system, the esophagus, the diaphragm, the heart, major thoracic blood vessels, and other mediastinal structures. And we'll get into these a little further in the lecture. Blunt chest trauma is more common than penetrating trauma. And in these pictures, you can see what blunt chest trauma looks like on the outside. The problem is that it's difficult to identify the extent of the damage going on internally, and that's why these are dangerous and life-threatening. Common causes for blunt chest trauma are motor vehicle accidents, often from the steering wheel and seat belts, falls, and bicycle crashes. And the reason they're often life-threatening is because you have associated hypoxemia, hypovolemia, and cardiac failure. And we'll get more into that in lecture. For assessment, we start out with our primary assessment, we go on to our secondary assessment, and we do a physical exam. And I want you to think about what each of those entails. We do a diagnostic workup, and then we do medical management. This slide shows an injury that a seatbelt can cause to the neck. So we need to look for this when we're assessing the patient. And I want you to think about what internal organs and vessels can be damaged by a seatbelt. So let's talk about sternal fractures and rib fractures. Sternal fractures are most common with motor vehicle accidents from impact of the steering wheel. They are not as common as rib fractures, but they still can occur. The signs and symptoms are anterior chest pain, tenderness, ecchymosis, crepitus, swelling, and possible chest deformity. Rib fractures are most common with blunt chest injury. The signs and symptoms are similar to sternal fractures with additional muscle spasm over the area, aggravated by coughing, deep breathing, and movement. Pain. Pain is definitely a sign and symptom. And what are the concerns and risk? I want you to think about that with this pain with rib fractures. We do a diagnostic workup. Medical management, the goal is pain relief, avoiding excessive activity, and treating associated injuries. Flailed chest is frequently a complication of blunt trauma. It occurs when 3 or more adjacent ribs are fractured at 2 or more sites, resulting in free-floating ribs, which you can see in the diagram here. Common causes, again, are motor vehicle accidents from steering wheel injury, motor vehicle accidents involving a pedestrian or cyclist, significant fall, and assault with a blunt weapon. The chest wall loses stability with resultant respiratory impairment and severe respiratory distress. In class, we'll discuss pathophysiology and the signs and symptoms of flailed chest. Again, we do a diagnostic workup. Medical management is usually supportive, including ventilator support, clearing secretions, and pain control. In this picture, we see a rib-specific plating system. And we're going to talk about that in class, and that's used when there is a severe flailed chest. Pulmonary contusion is a common thoracic injury associated with both flailed chest and blunt trauma. It occurs with damage to the lung tissues resulting in localized edema and hemorrhage. It's characterized by infiltrates and various degrees of respiratory dysfunction and failure. Again, we'll discuss pathophysiology in class and diagnostic treatments. The overall goal for medical management for blunt chest trauma is to maintain the airway, to provide adequate ventilation, and pain control. In this slide, you can see postural drainage, which is one therapy that is used, and it allows drainage of and movement of secretions in the lungs simply by adjusting the patient's position. And you can see that in these slides, the different positions that we use for postural drainage. And just as a reminder, blunt force trauma may be associated with greater than 50% mortality. So let's move on now to penetrating chest trauma. In penetrating trauma, any organ or structure within the chest is susceptible, including the chest wall, the lungs, pleura, the tracheobronchial system, the esophagus, the diaphragm, and major blood vessels. The potential for massive blood loss and exsanguination with both blunt or penetrating chest injuries is high due to injury to the great blood vessels. Diagnostic workup is performed. The goal of medical management is to restore and maintain cardiopulmonary function. So now we're going to talk about one of the major risks with chest trauma, and that's a pneumothorax. We have 3 different types of pneumothoraxes. They are spontaneous, also known as simple, traumatic, and tension. A simple or spontaneous pneumothorax occurs when air enters the pleural space through breach in the parietal or visceral pleural. It's usually through a rupture of a bleb, which is a small collection of air between the lung and visceral pleura, or a bronchial pleural fistula, and that is a pathological connection between the main stem, lobar, or segmental bronchus and the lung. It's associated with diffuse interstitial lung disease and severe emphysema. For traumatic pneumothorax, it occurs when air escapes from a laceration in the lung and enters the pleural space or from a wound in the chest wall. It occurs with blunt trauma from rib fractures. It occurs from penetrating chest or abdominal trauma, such as stab or gunshot wounds. And an open pneumothorax is one form. A tension pneumothorax occurs when air is drawn into the pleural space from a lacerated lung or small wound in the chest wall. It may be a complication of other types of pneumothorax, and in contrast to open pneumothorax, air enters the chest cavity with inspiration and then is trapped. In this slide, we see simple or spontaneous pneumothorax. And you can see there's air between the pleural layer and the lung with compression of the lung tissue. A traumatic pneumothorax may also occur during invasive thoracic procedures such as a thoracentesis, biopsy, or insertion of a subclavian central venous catheter. Often accompanied by a hemothorax after major injury from torn intercostal vessels, lacerations of the great vessels, or lacerations of the lung itself. And a hemothorax is just blood in the pleural space instead of air. A hemopneumothorax, where we have air and blood, is common after major trauma. Chest surgery can be classified as a traumatic pneumothorax. And the diagram on the right demonstrates a dislocated rib fracture puncturing the lung, which would result in a traumatic pneumothorax. In these diagrams, we see both a closed and open pneumothorax. The difference between a closed pneumothorax and an open one depends on the type of trauma that caused either wound. And we're going to go over this further in class so that you have a better comprehension of what's actually happening. A tension pneumothorax is actually a medical emergency and must be treated very quickly in order to maintain life. It occurs when air enters the chest cavity with inspiration, and a one-way valve-like mechanism causes the air to become trapped and cannot be expelled during expiration. With each breath, as you can see in the diagram, tension or positive pressure is increased within the pleural space. This causes the lung to collapse with a shift of the heart, great vessels, and trachea toward the unaffected side. I want you to think how this affects both cardiac and pulmonary function, and we'll go over the answers to that when we meet. In the left picture or diagram, we see a pneumothorax, and you can see air that is trapped between the pleura and the lung itself. The middle diagram shows a hemothorax where there is blood instead of air in that pleural space. And the right diagram shows a hemopneumothorax where there's a combination of air and blood. And it doesn't quite look like that. It's combined within the space. Signs and symptoms are dependent on the size and the cause. Varies from minimal respiratory distress, slight chest discomfort, and tachypnea to acute respiratory distress, anxiety, dyspnea with air hunger, increased use of accessory muscles, and it may develop central cyanosis from severe hypoxia. The goal of medical management treatment is to evacuate the air and blood from the pleural space, and a small chest tube is inserted in order to treat this. So here I'm going to delve a little further into the medical management of a pneumothorax. The medical management is dependent on the cause and severity of the pneumothorax. A small chest tube, a 28 French, is inserted near the second intercostal space. And this space is used because it's the thinnest part of the chest wall. It minimizes risk of contact with the thoracic nerve and leaves a less visible scar. Doesn't mean that they don't use other spaces, but that's the more common space. For hemothorax, when you think blood, it's thicker than air, so a large diameter catheter chest tube is used, and it's usually a 32 French or greater. Suction is applied, and that's usually 20 millimeters of mercury of suction to decompress the pleural cavity. The pleural cavity can be decompressed by either thoracentesis or by chest tube drainage, and the drainage systems we'll cover a little bit later in the lecture. A tension pneumothorax, a high concentration of supplemental oxygen, is used to treat hypoxemia, and pulse ox is used to monitor the oxygen saturation. In an emergency situation, a tension pneumothorax can be decompressed or quickly converted to a simple pneumothorax by inserting a large bore needle, 14 gauge, at the second intercostal space, mid-clavicular line on the affected side. And you see this a lot in emergency rooms or at the site of trauma, and you've probably seen it done on TV also. Moving on to thoracic surgery. A thoracotomy is the creation of a surgical opening into the thoracic cavity. It is performed to treat several different conditions: lung abscesses, lung cancer, cysts, benign tumors, emphysema. And the pictures on the right are just some graphic pictures of a thoracotomy. The diagrams here, A shows what normal lungs look like. B shows lung cyst. To the right, we see the alveoli with emphysema, what they look like between normal alveoli and alveoli with emphysema. And on the bottom, you see a lung abscess, and there's pus in the pleural space. These are 5 types of thoracic surgery. The first one, a pneumonectomy, is the removal of an entire lung performed predominantly for cancer when the lesion cannot be removed by a less extensive procedure. A lobectomy is removal of a lobe of the lung when the pathology is limited to one area of a lung. In a segmentectomy or segmental resection, single segments of the lung are removed. Care is used to preserve as much healthy and functional lung tissue as possible. For a wedge resection, removal or resection of a small, well-circumcised lesion occurs, and this procedure is performed for diagnostic lung biopsy and for the excision of small peripheral nodules. Video-assisted thoracic surgery, also known as VATS, is an endoscopic procedure to look into the thorax without making a large incision. For preoperative management, patients are typically admitted the day of surgery, which means a lot of the preoperative management starts in the outpatient setting. The outpatient surgical RN is responsible for both the preoperative assessment and education. And I want you to think about some of the things that you would educate the patient on. Anticipatory guidance to alleviate the anxiety experienced by the patient and family members is also provided, which really helps the patient in both their going into surgery and their post-op course. Postoperative management begins when the patient is transferred from the operating room to either the PACU or ICU if that's where they're being recovered. And the focus is your ABCs, your airway, your breathing, your circulation. So vital signs are checked frequently. Oxygen is provided by a mechanical ventilator or nasal cannula or mask, depending on what procedure they had done. And you have to remember that oxygen will be provided for as long as necessary due to the reduction in lung capacity after these types of surgeries, because it requires a period of physiological adjustment. And fluids are given at a low hourly rate to prevent fluid overload and pulmonary edema. Once the patient starts to recover from anesthesia, the head of bed can be elevated to 30 to 45 degrees. Positioning of the client depends on the type of procedure they had. So we'll go over which different positions for the different procedures in class. And pain control is very important. Medication is usually needed for several days after surgery, and it's provided through epidural analgesia, PCA, and scheduled or as needed oral analgesics, and it can be a combination of all or any of those. And splinting the chest for coughing and deep breathing is extremely necessary. Chest tube drainage systems come in essentially 2 types. There's the water seal system or wet suction and dry suction water seal systems. We see the water seal system or wet suction. The middle diagram, or the diagram to the left, just basically breaks down what's happening in those systems, where you have your fluid collection area, you have your water seal area, and you have your pressure regulating bottle. So first I'm going to discuss water seal system, or wet suction, for chest drainage. In the wet system, there are three chambers: a collection chamber, a water seal chamber, and a wet suction control chamber, which in diagram A is all the way to your left. The collection chamber acts as a reservoir for fluid draining from the chest tube. It is graduated to permit easy measurement of drainage. Suction may be added to create negative pressure and promote drainage of fluid and removal of air. The suction control chamber regulates the amount of negative pressure applied to the chest. The amount of suction is determined by the water level. It is usually 20 centimeters of water, and adding more fluid increases the suction. So you can see there that it's marked at 20 where the water, and there is some color in there so you can see it's blue. Suction is turned on and bubbling appears in the suction chamber. Intermittent bubbling in the water seal chamber is normal, but continuous bubbling can indicate an air leak. Bubbling and tidling do not occur when the tube is placed in the mediastinal space. However, fluid may pulsate with the patient's heartbeat. If the chest tube is connected to gravity, drainage only, suction is not used, meaning you don't attach the system to the wall suction. If the chest tube and drainage system become disconnected, air can enter the pleural space, producing a pneumothorax. To prevent a pneumothorax, a temporary water seal can be reestablished by immersing the chest tube's open end in a bottle of sterile water. As you can see, the two systems look a little bit different, and I'm going to discuss B, the dry suction water seal system. Dry suction water seal systems have a collection chamber for drainage, a water seal chamber, and a dry suction control regulator, and that's up in the left top hand corner in picture B. The water seal chamber is filled with water to the 2 centimeter level. Bubbling in this area can indicate an air leak. The dry suction control regulator provides a dial that conveniently regulates vacuum to the chest drain. The system does not contain a suction control chamber filled with water. Without a water-filled suction chamber, the machine is quieter. However, if the container is knocked over, the water seal may be lost, and that's really important to remember. Wall suction, the regulated dial allows the desired level of suction to be set. The suction is increased until an indicator appears, and you can see the bellows in E. The indicator has the same function as the bubbling in the traditional water seal system. Some drainage systems use a bellows or an orange-colored float device as an indicator of when the suction control regulator is set. Postoperative nursing management. Postoperatively, the patient may be managed by the nurse in the ICU, and it's usually for 1 to 2 days. Successfully managing transitions in care for the patient from the ICU to other inpatient acute care settings, for example, med-surg units, step-down units, to the outpatient setting is a key nursing responsibility. We focus on ABCs, as I said before: airway, breathing, circulation, pain relief, mobility and shoulder exercises, and there's a nice diagram in Bruner on that. Fluid volume maintenance, nutrition, monitoring and managing potential complications. Complications after thoracic surgery must be identified and managed early. In the diagrams you see in A and B a incisional infection with a wound vac. Down on the bottom on the left is the patient on a mechanical ventilator, and to the right bottom we see a pleural effusion. So some of these complications include respiratory distress or developing respiratory failure, arrhythmias, which are usually related to hypoxia. Bronchopleural fistula is a serious but rare event. It prevents return of negative intrathoracic pressure and lung re-expansion. Depending on the severity, it's treated with chest tubes and mechanical ventilation. Hemorrhage and shock. We treat the underlying cause by reoperation or administration of blood products or fluids. Atelectasis, obviously that's one because the patients don't really want to cough and deep breathe because of the pain. Incisional infections, which you see in the diagram. Pulmonary infections or pleural effusions are often preceded by atelectasis, and they may occur a few days into the postoperative course. Pneumothorax may occur if air leak from the surgical site to the pleural cavity or from the pleural cavity to the environment occurs. Pneumothorax is often accompanied by a hemothorax in these cases. Pulmonary edema can occur from overinfusion of IV fluids and is a significant danger. The early symptoms of pulmonary edema are dyspnea, crackles heard in the lungs, tachycardia, and pink frothy sputum. This constitutes an emergency and must be reported and treated immediately. This slide and the next two slides really show what we do to prevent complications after any kind of thoracic surgery. So I like this slide, these pictures, because it shows how you can help the patient splint after thoracic surgery or thoracic trauma. So coughing and deep breathing, absolutely essential along with the use of an incentive spirometer. And those of you that know me know I always say every patient in the hospital needs both of these. In this slide, we see chest physical therapy in the form of postural drainage, which we talked about a little bit earlier, and also the clapping on the chest you can see in A, B, and C hand position and patient position, which really helps mobilize secretions in these patients. Some patients need more aggressive chest physical therapy, and we can use high-frequency chest wall oscillation vest. And as you see in the picture, it's a vest attached to the machine. The vest goes around the patient's chest, and basically what it does is it vibrates and oscillates so that it can mobilize secretions for these patients. So from what we've discussed, what nursing diagnoses can you develop for the post-thoracic surgical patient? Some patients develop pleural effusions, and it can be a couple of days after surgery or sometimes even weeks later for any type of chest surgery. A thoracentesis is the insertion of a needle or catheter into the pleural space to remove fluid that has accumulated and to decrease pressure on the lung tissue. It may also be diagnostic to identify causes of the pleural effusion. Pleural effusions are common, as I said, after chest surgery and also after cardiac surgery. And so you can see the patient is positioned in a sitting position with their arms on, usually we use the bedside table with a pillow on it. A needle is inserted with a catheter into the back, and it's attached to a bottle that has a vacuum seal in it. And once they release the seal, the fluid collects in the bottle. There's also a Y connection where you can attach a syringe, and this is how specimens are collected and are sent for a bunch of number of things, including blood cell counts and different types of infectious processes. This concludes the voiceover for chest trauma and chest surgery. Come to class prepared to answer the questions that I posed during this and also to talk about some case studies. Thank you.